Welcome to the TCT Middle East and welcome to this specific session, Radcliffe session focused on intracoronary imaging. I am Dr. Hammami from Tunisia, interventional cardiologist. I am so pleased to be joined today with two experts in this field, Dr. Mamas, an interventional cardiologist from UK, and Dr. Alameer, an interventional cardiologist from PSA. So we know that the use of intracoronary imaging is evolving and continue to growing up with the publication of new recommendation and new data. And my first question to Dr. Mamas, in your daily practice, do you use these modalities in every patient, in every lesion, or you will use only in a specific lesion, complex lesion? And what about the setting of acute coronary syndrome with a high risk of thrombotic complication?
So thank you for your question, Rania, and it's a real pleasure to be here alongside two friends. So in relation to intracoronary imaging, I use it for every single case. Every PCI that I do has intracoronary imaging, irrespective of whether it's stable cases, complex cases, acute cases, or even STEMI. It depends on the type of case as to whether I choose IVUS or OCT. I think we often talk about PCI, but I also think that actually intracoronary imaging helps us in deciding whether to do the intervention. So many of the cases that I perform intracoronary imaging in, I decide after doing the intracoronary imaging, actually, this can be medically managed. And I think that's an area that many of us forget about the utilization of intracoronary imaging in these cases.
And maybe another question for Dr. Alameer. We know if you have in our cath lab at the same time we have IVUS and we have OCT, in which lesion you will prefer one modalities over the other one? I talk about especially the lesion of left main.
Okay, so sometime actually you have luxury that you have both modality in your cath lab, which is good. And most of the cases, it's okay to use either of those modality. In some cases, and you mentioned the left main, that you need actually maybe to choose one over another. We know that the IVUS, it's good modality to assess left main severity, and we have data for that, robust data. We don't have that regarding the OCT. But if you are sure about the severity of the lesion, just to plan your PCI for the left main, I think both modality are okay. And we have the October trial, which showed that the OCT, superior to angiography alone in bifurcation lesion, includes some of left main patients.
Okay. And we know that maybe we can get few complications. It's an invasive procedure. And Dr. Mamas, what are the tips and tricks to avoid such complication? What are the percentage of this complication when using these modalities?
I mean, look, the complication rates are low, and you also got to think, how about avoiding complications and using these procedures? So, for example, in women that come in with an acute coronary syndrome, SCAD is something you have to think about. It's not always obvious from the angiogram. As if you stent a lesion, that can cause a complication. If you identify it with intracoronary imaging, you can avoid that complication. Calcification, sometimes it's not that obvious from an angiogram. And so deploying your stent without doing intracoronary imaging, and you get poor stent expansion, or you end up with a perforation, that's a complication. Whereas being able to identify this up front will avoid the complication. In relation to complications with the devices, I mean, clearly with OCT, I mean, you spoke about the October trial. We know that clearly with OCT, you have to use contrast, and there is a risk of contrast-induced nephropathy, although the rates are very low. In patients with significant renal dysfunction, there are ways around that. So you can use IVUS instead, or you can use OCT with saline and not use contrast at all, but just make sure you flush both the OCT catheter with saline rather than contrast before you use it. And again, OCT with saline gives you very good pictures. So I think, in my view, people talk about complications. I think they're very low. And actually, using these devices prevents complications from happening and also guides you into sometimes not doing PCI and can be cost effective as well. So to give you an example, in acute coronary syndrome cases, we have a lot of good data, particularly for erosions that you would see with an OCT with a good MLA, that you can move those and manage them medically. We have data from the Erosion 2, Erosion 3 study to show that actually the MACE rates of these cases are very low. So again, you're sort of using your devices to avoid PCI, avoiding patients coming back. We have several cost effectiveness analysis, including one from the UK that we did with IVUS. We've got one from the US. We've got one from Australia showing us in the longer term, because you avoid MACE, you avoid having to re-intervene. These devices are cost effective.
So you encourage all the interventional cardiologists to use their modalities in every patient. You consider that the risk of complication is very low, and we have to use it in every patient in 2025.
I would say this.
For simple lesion, I mean.
Yes, so it depends on the healthcare system that you're working in. I do voluntary work in Ethiopia. I spend 2 weeks every year in Ethiopia doing cases. They don't have intravascular imaging there. I'm in the largest government hospital. They don't have it. So there, I'm having to do left main cases. I'm having to do ACS cases without intravascular imaging. It's not ideal, but that's what you're faced with. In my centre, and I guess in your centre, we have the funding to support intravascular imaging. And so I think, in this era where we have data both for complex PCI, but also non-complex PCI. So data from the Ultimate trial, for example, showed there was no interaction in terms of efficacy by complexity. So patients with a type A or B1 lesion had as much benefit as a B2 or C lesion. So my view is, use it in every case. Ensure that you optimize your case. And I always give this discussion to my fellows. I say, if you're driving along the road and you see a big boulder in the road, that's not dangerous. Anyone can see that. You stop. The most dangerous boulders are the ones that you don't see, the small rocks that you don't see that you drive over. That's the one that causes the problems. And again, with intracoronary imaging, you may think this is a simple lesion. If you do the imaging, you may see that it's no longer as simple as you believe. Sure. I mean, what do you think?
So regarding using of intravascular in each case, actually, to be honest, I don't do that. Sometimes because the workflow and the number of cases, but I tend actually to use it whenever I can. Probably I use it in 60 to 70% of my cases. Even if I think that it's simple, I do it. Because usually it will not take time unless for me to do the pull pack and decide what to do. It's just a preparation. If it's not ready, then it might take a bit of, few minutes, maybe more.
I mean, Rania, I guess the thing that I would like to sort of say to the viewers of your excellent interview is this. We often think that imaging is a magic wand where you wave it and immediately everything gets great. And it's not. It's not using imaging that impacts on outcomes. It's using imaging and achieving the optimal expansion of your stent. It's making sure that you don't have distal edge dissections. And we consistently see from all the imaging trials where they've looked at it, from October through to Occupy, through to some of the Renovate Complex PCI, that the benefit of imaging is only when you achieve optimal expansion and optimal imaging result. If you don't achieve that, your results are no better than the angiogram arm. So it's not a magic wand that you stick down the coronary. It's using the information, getting an optimal result, in my view anyway.
Yes, sure. But I think with the development of CT scan, the FFR CT, we have also negative data about the use of ischemic tests like FFR, PFR, especially in free vessel disease. What do you think? How do you see the future of intracoronary imaging in the era of this competition between all these modalities?
So we use cardiac CT and CTFFR a lot in my centre. To my mind, it provides two pieces of information. Number one, should I put the patient on the table? Do they need a cath? So if you have someone with with a CT saying, yes, they've got arthroma, but the CTFFR, the non-invasive test, is negative, actually, why do the angiogram? There's no benefit here. Aggressive secondary prevention, data from Scott Hart showing a mortality benefit. The second piece of information that it gives me is if there's lots of calcifications of plaque characterization, I know up front, maybe I should save this case, make sure I have the rotablation, make sure I have the lithotripsy. And I guess the final piece of information, which I guess is sort of longer term, is the prognostic information. So, the patients that we all see that come in, they have a cardiac CT, it may be non-obstructive, but the CT findings of a high-risk phenotype. And so you say, actually, this is the patient. I need to be getting the LDL below 1.4, have a low threshold for PCSK9 inhibitor, bring their blood pressure control down. That's how I use it, but it may be very different to how you guys use it.
So maybe we will wait for the head-to-head comparison between all these modalities in the future. Thank you, Dr. Mama.
I think also that the CT, I don't think it will replace the intravascular imaging. Why is that? The CT, it will help me to plan the procedure maybe, but to check the result, did I achieve the optimal result or not, it should be by the intravascular imaging during the procedure.
I think if one day we will get CT in the cath lab,
Maybe.
it could be some innovation that will change our practice. Thank you, Dr. Mamas. Thanks
Thank
you,
you.
Dr. Alameer, and see you in another session.